Hello there, welcome back to the San Antonio Breast Cancer Symposium. And we're going to present some abstracts relating to randomized trials of chemotherapy. This is webcast 4, and I'm joined today by Anna Rigg, who is a medical oncologist from Guy's Hospital, and Dr. Hartmut Christolite, who is a medical oncologist also from Guy's Hospital, and I'm Susie Kletor, breast oncologist from Imperial. So over to Hartmut for the first of the presentations.
So the first study we're going to talk about today is a TNT study, which is probably one of the most anticipated trials presented at this year's San Antonio. The TNT study is a study of first-line chemotherapy in patients with triple-negative breast cancer or a genomic BRCA1 or BRCA2 mutation. It randomized 376 patients with metastatic or recurrent locally advanced triple-negative breast cancer or BRCA mutation breast cancer to either 6 cycles of carboplatin at AUC 6 or 6 cycles of docetaxel at 100 milligram per meter square, again for 6 cycles. The study is unusual in that it has a crossover design, and patients were allowed to cross over to the alternative arm on progression. Patients with recent exposure to adventaxins were excluded, as were patients with prior exposure to platinum agents. First-line treatment with anthracycline chemotherapy was allowed. The background is that triple-negative breast cancer is, of course, a heterogeneous group, and 15% of unselected patients with triple-negative breast cancer are known to have a BRCA1 or BRCA2 mutation. BRCA mutations, as well as some subtypes of triple-negative breast cancers, are thought to have a defect in homologous recombination double-strand break repair, which confers sensitivity to platinum agents. No study so far has directly compared platinum-based chemotherapy with taxanes in this patient population. The primary outcome measure for this trial was an overall response rate, i.e. the proportion of patients receiving a complete response or partial response after 6 cycles of chemotherapy. Secondary outcome measures included the overall response rate in the crossover arm, progression-free survival, overall survival, toxicity, and subgroup analysis based on genomic mutation status and PAM50 subtypes. Here's the overall result of the study. There was no difference in overall response rate between carboplatin and docetaxel in the unselected patient population. Progression-free survival, again, was not statistically different, and median overall survival was not statistically different. Dose intensity was similar for both drugs, and there was no difference seen in the crossover arms. Toxicity, as one would expect, there was more neuropathy and febrile neutropenia seen in the docetaxel arm, and carboplatin in general was better tolerated. If we look at the subgroups, we see some interesting results. In BRCA mutant patients, the response rate to carboplatin was 68%, whereas to docetaxel this was only 33%. In BRCA wild-type patients, there was no statistical difference. If we look at the PAM50 subgroup analysis, basal-like patients had no difference between carboplatin and docetaxel, whereas the non-basal subtype group, and I have to say that this was a very small group of only 36 patients, showed a significant difference with a response rate of only 16% to carboplatin and an astonishing 74% to docetaxel. Here's the Kaplan-Meier curve of progression-free survival to carboplatin based on the BRCA mutation status. And you can see that patients with a BRCA germline mutation have an almost doubling of their progression-free survival. And this is the response rate based on the PAM50 subset. And you can see the astonishing response rate to docetaxel. In conclusion, the triple-negative trial provides no evidence of superior response to carboplatin compared to docetaxel in unselected triple-negative breast cancer patients. Patients who have a genomic BRCA1 or BRCA2 mutation experience significantly greater responses and progression-free survival with carboplatin than comparison to docetaxel. The surprising response rate in the non-basal subtype to docetaxel warrants further investigation. And finally, the TNT trial supports BRCA genotyping in, I believe, all patients with triple-negative breast cancer.
And now I'm handing over to Dr. Anna Rigg, who's going to present the results from two large phase 3 studies. One study looking at different schedules of anthracycline chemotherapy and another study looking at different schedules of taxane adjuvant chemotherapy. Thank you.
Thank you, Susie. It was a very packed and busy session this morning, and the two trials I'm going to present really took me back in time, as they are traditional bread and butter chemotherapy trials which we all grew up with. The first trial I'm going to talk about is the NSABP B36 study. It was a randomised phase 3 trial, and it was comparing 6 cycles of FEC 100 chemotherapy to 4 cycles of adriamycin and cyclophosphamide in patients that had node-negative breast cancer. And the defined primary endpoint of the study was to see whether FEC 100 was superior to the AC in terms of prolonging the patient's disease-free survival in node-negative disease. In terms of secondary endpoints, the investigators were also interested in overall survival, adverse events as you'd expect, and obviously quality of life for patients. In terms of the results that we were shown this morning, the patients in both arms of the study were well matched, and we're now up to a point where there's median follow-up of almost 83 months. The primary and secondary endpoint analysis at 8 years has not revealed any difference in terms of disease-free survival, overall survival, the relapse-free interval, or the distant relapse-free interval. When we were shown the toxicity data, the grade 3 and 4 toxicities were very much as you'd expect with an anthracycline regimen, and were more frequent in the FEC 100 arm. In particular, the hematological toxicities were higher with FEC 100 than with AC. And interestingly, we were shown data about left ventricular systolic dysfunction. It only occurred at grade 3 or higher level in 1 patient in each arm. Overall, there were 2 toxic deaths in the AC treatment group, and there were 5 deaths in the FEC 100 group. In conclusion from this study, the investigators have demonstrated that 6 cycles of FEC 100 does not improve the primary endpoint of disease-free survival or the secondary endpoint of overall survival relative to having 4 cycles of adriamycin and cyclophosphamide. The toxicities were clearly increased in the FEC 100 group, and interestingly, there wasn't, despite the fact there's now been quite long follow-up, there was no data presented about the incidence of hematological malignancies in either arm. The projections on the disease-free survival event rates for adriamycin and cyclophosphamide were accurate. The symptomatic congestive cardiac failure rates appear to be rare in both arms and equal. So the authors concluded that the results do not support the use of 6 cycles of anthracycline-based regimens in node-negative breast cancer patients. This was a phase 3 study in which all patients had doxorubicin and cyclophosphamide, and it was followed by either paclitaxel or docetaxel, and the taxane was either given 3 weekly or once weekly. And the patients in the study had either had node-positive breast cancer or high-risk node-negative breast cancer. This trial originally commenced in 2004, and the data has previously been shown and published, at which point they had just over a 5-year median follow-up. And at that point, they'd already demonstrated that there was an improvement in disease-free survival with either the adjuvant weekly paclitaxel or the 3-weekly docetaxel as compared with 3-weekly paclitaxel. And in the original reports, both obesity and black ethnicity independently were associated with inferior outcomes in those patients that had estrogen receptor positive disease. So now they were showing us updated data from the patient cohort with a median follow-up of 12 years. Interestingly, 90% of the surviving patients have been followed up for at least 10 years, which in my experience is an incredibly good follow-up rate for patients. and the primary endpoint remains disease-free survival, which they defined as either local, regional, and/or distant relapse, secondary, primary breast cancer, or death without recurrence. And the comparison was made between the taxane agents and also between the schedule of the individual taxane agents. So this schema just really goes over what I've mentioned already. Women had to have axillary lymph node positive breast cancer or what the investigators deemed to be high-risk lymph node negative breast cancer. After randomization, all of the patients had 4 cycles of AC at standard doses, and then they were randomized. In the 3-weekly paclitaxel arm, they had what we would consider in the UK a standard dose of 175 milligrams. The intravenous 3-weekly docetaxel, again, standard dose of 100. The weekly paclitaxel was 80 milligrams weekly, and the weekly docetaxel was 35 milligrams once weekly. And those patients that had ER-positive cancers were allowed to receive endocrine therapy for at least 5 years after their chemotherapy. So the results, and I have to confess, all of us, when we watched this, found this a very confusing presentation, so I shall attempt to take you through it. When paclitaxel, whether it's once weekly or 3 weekly, was compared against both docetaxel arms, there was no difference in terms of either overall survival or disease-free survival. They then went on to compare the weekly versus the 3 weekly, whichever drug it happened to be, and again there was no difference in terms of the overall survival or the disease-free survival. And then the final permutation that they looked at was comparing taxane within itself by schedule, so i.e. paclitaxel weekly versus paclitaxel 3 weekly. And this time there was a significant difference in both overall survival and disease-free survival. They also, in the presentation today, mentioned a couple of exploratory analyses that they have looked at. The first was relating to the patients that had triple-negative breast cancer who were included in the study. And the analysis that they've done showed that the weekly paclitaxel arm appears to be associated with an improved disease-free survival and overall survival, as opposed to the other arms in the study. Those patients that had ER-positive and HER2-negative or HER2-unknown breast cancer seemed to have a trend towards a benefit from the 3-weekly docetaxel, but this did not reach statistical significance in terms of overall survival. And finally, again, as is shown in the first presentation a couple of years ago, ethnicity and having a body mass index of more than 30 was associated with inferior overall survival. So in conclusion, for the entire population studied, adjuvant weekly paclitaxel and 3-weekly docetaxel were associated with significant improvement of disease-free survival and a marginally improved overall survival compared with the 3-weekly paclitaxel. For the triple-negative patients, the most effective taxane regimen appears to be the weekly paclitaxel, and from the data we were shown, the 10-year disease-free survival for these triple-negative patients improved from 59% to 69%, and the overall survival rate improved from 66% to 75%. The ER-positive and HER2-negative or unknown, the difference in the arms was much smaller, but as I mentioned, there's a possible trend towards the 3-weekly docetaxel being the best regimen. Finally, again, relevant for our current world, obesity and ethnicity do seem to have an effect on outcome.
Okay, thank you, Anna. So going back to the NSABP study, so this is, just to summarise, a study of really the most intensive anthracycline regimen that you can have. 6 cycles of FEC 100, which we don't actually use routinely in the UK now, but which we think is probably no better than what we do use a lot in the UK, which is 6 cycles of FEC75. And it's comparing it with a shorter and simpler regime and cheaper regime that, you know, is going to be better tolerated. So how's it going to change what you do when you go back to the clinic next week?
I think it is a game changer. I think for the people who are high enough risk to need chemo but are at the low end of that spectrum, so particularly the node-negative patients.
But even some node-positives, yeah.
Yeah, absolutely. I think we should be changing to the 4 cycles of the AC rather than continuing with 6 cycles. And certainly at our next regional away day, something I'll want to discuss.
Yeah. And then, the other thing we were talking about earlier is that we know that higher doses of epirubicin is associated with, you know, a significant risk of leukemia, AML in particular. I can't remember the timeframes. The follow-up here was 7 years, wasn't it? But you know, we would much rather use smaller doses of anthracycline. So, you know, from a leukemia point of view, that we would expect that to be beneficial, certainly.
Yes, and I don't know if it's long enough follow-up to be completely clear about the cardiac implications either.
No, exactly. Okay, so that's offloading the chemotherapy unit a little bit. You know, we're thinking that maybe when we go back, instead of using 6 cycles of FEC75, we're going to switch over to 4AC. So that brings us on to the next presentation that we're going to discuss. And that was the E1199, looking at 2 different taxanes and 2 different regimens, 3 weekly and weekly. So just to summarise here, it does appear, as in the earlier analyses, that weekly paclitaxel seems to be the best way of delivering taxanes in the adjuvant setting, and we've had studies showing that in the metastatic setting as well. And in the higher risk patients here, the triple negatives, which are probably the patients that are going to benefit most from taxanes, that effect was most marked. So again, I would ask you, how is the data from this study going to influence your local chemotherapy guidelines? I
mean, I think I'd be much more in favour of using weekly paclitaxel, more so than I have done previously, particularly I think in the triple negative patients, although I think a note of caution, it wasn't a planned analysis, and I can't remember the percentage of patients, but it would be reflective of what you'd expect in the population, so it would be a small group of patients. So I think, you know, there is a gradual move towards doing more weekly taxane treatments. Certainly it's, in my experience, very well tolerated relative to the big swings of 3 weekly treatment.
And what about this slight signal in the ER positives that maybe 3 weekly docetaxel might be better? Do you make anything of that?
Again, it was an unplanned analysis, and
the curves were all very close together.
Yes, that's right. We haven't had time today to show the actual survival curves, but they really were almost lying over one another. It was a very small difference. And then the other thing that I was going to come on to at the end was just, you know, more data showing that on multivariate analysis, obesity is a marker of adverse outcome, as is black ethnicity. So they did mention about where they were taking their weight measurements, didn't they? Yes, I think they only measured weight formally at baseline. It wasn't monitored as part of the trial proceedings. So it's difficult to know about that, and certainly there's no follow-up data on the weight of those patients.
Yeah, and they didn't break it down according to ER status either, did they? Because in the past, most of the the studies that have looked at obesity have suggested that it's more a factor in the ER negatives or those not taking endocrine therapy. And the black ethnicity, I mean, that's probably multifactorial, isn't it?
Yes, I think again there were questions at the end of the presentation about the case mix and whether it was to do with late presentation or social deprivation or socioeconomic deprivation factors, and actually that information wasn't there. So again, it's really difficult to know about that. But I think there's plenty of information from other sources that shows that.
So we've got two presentations there, quite kind of old drugs, nothing particularly exciting, but we're probably going to change what we do on a daily basis. Yeah.
Yes.
Okay, so we're now moving back to Dr. Christelite, who's going to tell us about the phase 3 ICE study that was presented this morning.
Yes, this is another interesting, provoking study coming out of Germany. The ICE study is a study looking at elderly patients which are historically underrepresented in clinical trials and offers those patients adjuvant ibandronet plus or minus adjuvant capecitabine. As a background, anthracycline or combination chemotherapy is often thought to be poorly tolerated in frail and unfit elderly patients. Capecitabine is known to have single-agent activity in the metastatic setting. In addition, elderly patients have high incidence of osteopenia and osteoporosis, fractures and bone surgery, especially when on a aromatase inhibitor, so offering those patients adjuvant ibandronet is of interest. And we know, of course, from various trials and a meta-analysis presented last year, that adjuvant bisphosphonates increase distant disease-free and overall survival in postmenopausal women with breast cancer. So the study design, it's a large study of 1,358 patients, all older than 65 years of age, with poor prognostic breast cancer, either defined by node-positive disease or a grade 2 to 3 cancer greater than 2 centimeters or hormone receptor negative. The study used the Charlson Comorbidity Index, and patients who were thought to have a high risk of comorbidity and death from comorbidity were excluded from the study. The study randomized, as said, to ibandronet 50 milligram orally daily or at patient's choice intravenously at 6 milligram every 4 weeks for a total of 2 years, plus or minus the addition of capecitabine at the reduced dose of 2,000 milligram daily under the usual schedule of 2 weeks on and 1 week break for a total of 6 cycles. Unsurprisingly, there was more toxicity seen in the chemotherapy arm, with 31% grade 3 or 4 toxicity and only 8% in the ibandronet arm, but there were no new safety signals, and the adverse events were the usual diarrhea and hand-foot syndrome. If we look at the results, there is no difference in invasive disease-free survival at all between the two arms, and there is no difference in overall survival. What you note is the surprisingly good outcome of this elderly population with what's thought to be poor prognosis breast cancer, where 90% of these patients are alive at the 5-year follow-up point with or without chemotherapy. So in conclusion, the ICE study fails to show that the addition of capecitabine improves invasive disease-free survival or overall survivals over and above ibandronet. Outcome of elderly patients with moderate and high-risk breast cancer on this study was excellent with ibandronet alone. Oral ibandronet was preferred over the IV formulation, and bone-related events, I didn't show you that slide, was very frequent, with 25% of patients experiencing bone-related events. So the use of bisphosphonates is warranted in this patient population. It's thought that the excellent overall outcome might be due to the fact of a high proportion of luminal-type tumors in this patient population, and the authors suggest that longer follow-up is warranted to confirm the role of capecitabine in this trial. But they also conclude that this study, together with the CLBG 49907 study that showed benefit of combination chemotherapy over capecitabine, supports the use of combination chemotherapy.
Thank you. So, I mean, not necessarily particularly surprising results given the previous CALBG study. You know, 5-FU alone in breast cancer in general may not add a lot. I mean, what do you think this says anything at all about treating women of this age group with chemotherapy in the adjuvant setting?
I think it does, because it tells us that although those women might be elderly, they have a very good life expectancy. Mm-hmm. And I think patients who have a high-risk cancer and who are at risk should be offered combination chemotherapy and not single-agent capecitabine. But in general, those patients will do well. And I think as a take-home message for me, it reinforces the need to offer those patients adjuvant bisphosphonates.
Yeah. And also we were talking earlier that this study had built into it as part of the selection process a frailty score. And you know, that's not something that most of us are doing formally. So, you know, most of the patients tolerated their treatment fairly well. It wasn't without toxicity. But, you know, we're going to be treating more and more elderly people, and I think we need to embrace using these scoring systems, don't we?
Absolutely.
And yes, the adjuvant bisphosphonate story, well, it would be, you know, we don't know what the level of bone events would have been without the abandonate, but it was frighteningly high even with it, wasn't it?
Yes.